I want you to take a second and look at your wrist. Can you feel your pulse?
Got something.
Right. It feels so mechanical, simple. Now imagine taking that feeling and translating it into a visual language. And that's basically what a 12-lead EKG is. It's that pink grid paper with all the black squiggly lines that, well, to most people, it looks like a seismograph during an earthquake.
It definitely looks chaotic to the untrained eye, yeah. But to a clinician, that grid is supposed to be the absolute truth. It's the gold standard for any cardiac assessment.
Right, the gold standard. But here's the idea for today's deep dive, and honestly, it's a little unsettling. What if I told you those lines are an incomplete code? What if reading those lines without knowing the person attached to them is like trying to read a novel where every third page has been ripped out?
That is a perfect analogy. We're looking at a stack of research today that suggests we have this massive blind spot in cardiology.
A blind...
Yeah, we tend to treat the EKG as a standalone tool. The machine spits out a diagnosis, and we trust it. But the data shows that without that invisible link, the patient's history, we might be reading a completely different story.
The invisible patient. I love that. So the mission for this deep dive is pretty clear then. We need to figure out how knowing the story actually changes the diagnosis.
And how the rhythm itself can whisper secrets about a patient's past. And, we really need to talk about the dangers of relying on the machine.
We have some pretty alarming data on that, don't we? Especially with the automated interpretations.
I do.
We're talking AI-assisted diagnostics failing nearly 40% of the time. The rise of telenursing, where you're watching patients you'd never even met.
And why your cell phone might trick a doctor into thinking you're dying.
It's such a strange mix of high-tech problems and, I guess, very human solutions.
It really is.
Before we get into the weeds, I do want to mention that this deep dive is brought to you by Whole Life Healthcare. Their whole philosophy is about seeing the patient as a complete person, not just a set of symptoms, which, it tracks perfectly with what we're talking about.
Oh, absolutely. In medicine, context is everything.
So let's start with the skeptical view. I'm a data guy. Is this whole history matters thing just a nice sentiment they teach in nursing school to make you compassionate? Or does it actually change how you read the squiggles?
It's not just a sentiment. It is a statistical fact. There was a study in BMC Medical Education that's frankly a little startling.
Oh, yeah?
They wanted to measure exactly how much clinical context weighs on your diagnostic accuracy.
So how do they set it up?
They took a group of doctors, everyone from junior residents to seasoned pros, and just gave them ECGs to interpret. First round, they got the strip in a vacuum, just the lines.
Flying blind? No name, no age, no complaints?
Nothing. And how do you think they did?
I'm guessing not great.
Poorly. The mean accuracy was only about 30.2%.
30%. That seems incredibly low for doctors. That's an F-.
It just highlights how ambiguous these waveforms can be without any clues. But then, they gave the same doctors the same ECGs, but this time they added intelligently screened key clinical information.
So the patient history. 70-year-old male, diabetic, complaining of jaw pain, that kind of thing.
Exactly. And the scores went up.
They had to.
Significantly. They jumped to 36.2%. Now, I know what you're going to say. That's only a 6% bump.
I was going to say exactly that. It doesn't sound earth-shattering when you just say the number.
But in diagnostics, a 6% improvement in accuracy is massive. That's thousands of lives over a career. And if you drill down into the data, the effect on junior doctors, the people still learning the ropes, it was profound. Their scores jumped by nearly 27%.
Wow. Okay, so for someone less experienced, the history basically acts as a guardrail.
Exactly. It proves the lines don't exist in isolation. If you don't have the history, you're just guessing. You're matching shapes, not diagnosing a person.
So let's flip that. What happens when we stay in the dark? We've got this source on clinical and systemic determinants of misinterpretation. It talks about triage failure.
And this is the scary part. When you lack history, you're statistically much more likely to miss high-risk findings, especially in certain populations. Think about the elderly or diabetics.
Right, because they don't always read the textbooks. They don't come in clutching their chests like you see in the movies.
Correct. We call them atypical presentations. A diabetic might have a silent MI, a heart attack with no pain because of neuropathy. They might just feel a little nauseous or tired.
And if the person reading the EKG doesn't know the patient is diabetic, They see a subtle, non-specific change on the graph, and
And they dismiss it. They think, oh, it's just
so it
noise.
creates a falsely normal perception. You see what you expect to see.
Precisely. And this connects to a concept in the research called visual search patterns. This is really cool cognitive science.
I love this part. They actually tracked where the doctor's eyes were looking on the page.
Yes, eye tracking research. It shows that experts and novices physically look at an EKG differently. But here's the real kicker. When an expert knows of the clinical history, their eyes move differently than when they don't. They focus immediately on the high-yield areas relevant to that history.
So if I tell you chest pain, you zoom in on the ST segments. If I say palpitations, you're looking at the rhythm strip.
And without the story, even the experts get scattered. Their eyes just dart around the page. They don't have a hypothesis to test, so they're just hunting.
So the history acts like a map. It tells your brain where to spend its processing power.
That's a great way to put it.
Okay, but here's the logistical problem. That all works if you're the doctor standing at the bedside. But healthcare is changing. What if you're a monitor tech sitting in a war room 3 floors down or in another building entirely?
The ghost in the machine problem.
Right. These are people watching lines for patients they've never met. How do you bridge that gap? How do you get the history when you can't even say hello?
This is where the model of care is shifting toward what they call flexible monitoring and telenursing.
Telenursing sounds like a robot is about to check my blood pressure.
Right. But the reality is it's a practical solution to the shortage of eyes on patients. You have these centralized monitoring units where a single technician could be watching up to 40 patients at once.
40? That sounds like a recipe for disaster. How can you possibly know the story for 40 different people?
You can, not by memory. But these units are evolving. They're becoming virtual units. The tech isn't just staring at a waveform on a wall anymore. They have these integrated workstations.
So they have the digital chart open right there.
Yeah, some of the newer systems are designed to pull admission notes, medication lists, lab results right onto the screen alongside the rhythm. So the monitor watcher isn't just seeing a squiggly line go weird. They can glance at a sidebar and see, oh, Mr. Jones is on Sotalol.
Which is a high-risk cardiac med.
Right. Or he was admitted for heart failure, not a broken hip. They're interpreting the rhythm through the lens of that digital history. It turns them from being passive observers into an active safety net.
It totally changes the job description. You aren't just a security guard watching a CCTV camera, you're an investigator.
You have to be.
Speaking of being an investigator, I want to pivot to my favorite part of the research, the Sherlock Holmes stuff. Sometimes the system fails. You don't get the history, you don't have the chart. You just have the rhythm.
The deduction phase.
Yes. There was this fascinating discussion on All Nurses about connecting the dots. It's about reading the history from the ink on the page.
This is such a vital skill in telemetry. The rhythm itself is a physiological story. It tells you what the body is struggling with chemically.
Okay, give us some concrete examples. If I'm looking at a strip, what's a clue that screams, go check the history?
All right, take T waves. The T wave represents the heart resetting electrically. Normally, it's this nice round bump. But if you see T waves that are suddenly spiked tall and pointy, like a tent, that trend is screaming about the kidneys.
The kidneys? How does the heart even know about the kidneys?
It suggests hyperkalemia, high potassium. Potassium is regulated by the kidneys, so if they aren't filtering properly, potassium builds up, and that directly changes the electrical repolarization of the heart.
So the EKG is basically telling you this person might have missed their dialysis appointment.
That's wild, isn't it? The heart is tattling on the kidneys.
It's all connected.
It is. Or look at heart blocks, specifically the Wenckebach block.
Longer drop. Now you have a Wenckebach. Yeah, I remember that rhyme from the source material.
It's a classic. Anatomically, the signal takes longer and longer to get through the AV node until it just fails completely and drops a beat. If you see that developing as a trend, meaning it wasn't there an hour ago, that tells a story.
What's the story?
It might mean the patient is having a reaction to a new beta blocker you just gave them. Or, much more seriously, it could mean they are extending a myocardial infarction.
Extending means the heart attack is getting physically bigger.
Exactly. The ischemia, the lack of blood flow, is spreading to the conduction system. The rhythm is giving you a real-time status update on tissue death.
That's terrifying, but incredibly useful. It also highlights why you can't just look at one strip. You need the movie, not just the snapshot.
Serial comparisons, yes. And one of our sources on automated interpretation errors pointed out this is the biggest weakness of AI. Algorithms have no memory.
They have amnesia.
Effectively, yeah.
Yeah.
And Algorithm looks at the snapshot it has right now. It sees deep Q waves, which indicate scar tissue, and it screams, "Alert! Heart attack."
But a human can.
A human technician can look at the EKG from yesterday or last year and say, no, that scar was there in 2021. This is chronic, not acute.
And that context saves the patient from getting rushed to the cath lab, pumped full of blood thinners they don't need.
And saves the hospital a ton of money and the patient a lot of panic.
Speaking of things that change the lines, there was this one detail in the source about lead placement mistakes that just blew my mind. It's about simple geometry. Patient position.
Ah, yes, the heart as a pendulum.
We don't think about it, but the heart isn't bolted to the spine. It hangs there. And the source said that just sitting up can change the QRS voltage by 10 to 20%.
It's significant. When you lie flat, the heart settles back. When you sit up to, say, 45 degrees, the heart drops and rotates slightly. The whole electrical axis shifts.
So play this out. I'm that tech in the basement. I'm watching the trend line from Mr. Smith. Suddenly, the voltage drops. The spikes get smaller.
If you don't know the context, your first thought is low voltage. You start worrying about a pericardial effusion fluid building up around the heart. That's a life-threatening emergency.
You're about to hit the panic button.
But in reality, Mr. Smith just sat up to eat his lunch.
That is incredible. The rhythm trend reveals the physical history of the patient just moving. But you have to be smart enough to ask, did he just move?
Or better yet, the bedside team needs to document that position on the ECG strip. Supine, semi-recumbent. It matters that much?
So we've talked about getting history and deducing history. Now we have to talk about the villains of the story, the imposters,
Artifacts.
the bane of our existence.
There's a warning here that sometimes the EKG is just. It's lying to you. And you guys have a great acronym for one of the most common issues, MISFIT.
MISFIT, myocardial infarction simulated from improper telemetry.
That sounds like a very polite way of saying you put the stickers in the wrong place.
That is exactly what it is. It's human error. If you place the limb leads on the torso instead of the limbs, or if you put V1 and V2 too high up on the chest, you change the angle of the camera.
And that angle change can create patterns that look just like ST elevation.
Exactly like a STEMI, a massive heart attack.
So how does history save you from that? Context is the filter. If the EKG shows a massive MI, but the history is healthy 20-year-old male here for a broken ankle, and the patient is currently laughing at a TV show.
You suspect a misfit before you suspect his heart is exploding.
You treat the patient, not the monitor. Always.
And speaking of modern problems, tell the listeners about the cell phone thing. This feels like something that just didn't exist 15 years ago.
Electromagnetic interference, or EMI. It's huge now. Everyone has their phone, usually resting right on their chest while they lie in a hospital bed.
Scrolling social media, texting family.
Right. But that device emits a signal, and the EKG leads pick it up. The scary part is that it doesn't always look like static. It can mimic specific, lethal rhythms.
Like what?
It can look exactly like atrial fibrillation, or worse, if the signal is strong and rhythmic, it can look just like ventricular tachycardia VTach.
That's a code blue rhythm.
It absolutely is. You see that? You grab the crash cart.
Imagine rushing in to shock a patient and they're just watching a cat video on TikTok.
It happens. And again, the history you need there isn't medical. The history is behavioral. Does this patient have a phone on their chest?
So how do you tell the difference on the strip?
Yeah.
Is there a tell?
Usually, yes. If it's EMI or even a tremor like from shivering or Parkinson's, the chaos is superimposed over the normal rhythm. You have to look for the notch or the spike of the real QRS complex marching through all that noise.
It's like spotting the ghost in the machine again.
You have to look through the artifact. If it were real VTach, you wouldn't see that underlying regular beat. If you see the regular beat hiding behind the squiggles, the patient is fine. They're just shaking or texting.
This really drives home the point that interpretation is an art form. It's not just pattern matching, it's critical thinking.
It is. It's detective work, really.
Before we wrap up, I want to remind everyone that if you're feeling a little overwhelmed by all these nuances, the blocks, the imposters, the lead placements, we've got you covered. Check the link in the description for the EKG Survival Pack. It's a great cheat sheet to keep in your pocket so you don't have to memorize every single thing we just talked about.
It is a very handy resource, especially for those visual search patterns we mentioned.
Also, we drop new deep dives every single Sunday, but we also sprinkle in bonus episodes when new research drops, so do us a favor and click that notification button. That way you really don't miss out.
And please, If you're finding value in this, if it helped you connect a few dots, go ahead and like, comment, subscribe, and share it with a colleague. It really does help us keep these conversations going.
So let's bring this in for a landing. What's the one thing you want our listeners to walk away with today?
I think the takeaway is that an EKG with outpatient history is like reading the middle chapter of a book. You might understand the individual words. You can identify a QRS or a T wave,
Yeah.
but you will completely miss the plot.
You need the context to make sense of the characters.
We need that clinical context, whether it's gathered at the bedside by asking, does it hurt? Or via these sophisticated data systems where you're pulling digital history. You need that story to tell the difference between true pathology and an artifact like misfit or cell phone interference.
And here's a final thought for you to chew on. We talked about how much we rely on machines, but one of our sources noted that automated interpretations have a 39% error rate, nearly 4 out of 10.
That's a staggering number.
It is. So if an algorithm can't see that a patient is shivering because they're cold, or that they're holding a cell phone, or that they just sat up in bed to eat a sandwich, are we approaching a dangerous tipping point where we trust the machine more than the story?
That's the question every clinician needs to ask themselves every single time they look at a strip.
Don't let the invisible patient stay invisible. Thanks for listening, everyone.
Stay curious.